What I'd like to do in the next few minutes is to talk about EPIC and quality improvement. And we'll look at using EPIC in different ways for quality improvement. Talk about a clinical data warehouse and using that for quality improvement, basically with a sort of a registry concept. And then talk a little bit about the Target BP MAP quality improvement program. And we've been doing this with several practices using EPIC, as well as other practices that are not using EPIC. But at the end of this, I'd like for you to understand some of the advantages and disadvantages of using EPIC, not only for your clinic system, but for also quality improvement, and to be able to describe at least two high-level strategies for driving QI using electronic health record, all of them, not just EPIC, and then understand the key elements of a quality improvement program and our current limitations of a single disease focus. We continue to write guidelines for individual diseases. In 2001, the Institute of Medicine said it's probably time to stop writing guidelines for individual diseases and write guidelines for patients that have multiple chronic conditions, because in fact, most patients with chronic disease have multiple chronic conditions. I won't spend a lot of time on it, that's a separate talk, but I think it's one of the limitations of healthcare today. So this was a review of EPIC that was published a couple of years ago, and it certainly allows one to acquire a lot of discrete and structured field information. So it's useful for collecting and managing interconnected information, certainly for longitudinal evaluation of data, and can advance the quality and value of patients' health care. But this rigor and accuracy of data with lots of information in discrete and structured fields comes at a price of increased workload on clinicians, I think particularly in the initial months of using the system. And then to be able to really use the data optimally, it requires a fairly substantial team of expert individuals, frontline clinicians, vendor-trained analysts, data system architects, and data specialists. For example, we in Greenville implemented EPIC about 3 years ago now, and we still have challenges implementing into EPIC all of the adaptations that really are required to drive our system. For example, I will be talking about our blood pressure quality improvement program, and we still run that separately from EPIC because it hasn't risen high enough yet. It's getting there on the priority list to actually be able to get the programming into EPIC to run the quality improvement program. But EPIC does provide data that can be integrated, analytical system add-ons, and really fairly sophisticated analyses, including some of the cost issues that we need. But oftentimes the vendor support and add-ons are costly, and I think a lot of people that implement EPIC underestimate the costs of refining the system and the long-term operating costs of using that model. But on the other hand, it can give you some excellent information, and during the point of care, it can do a lot to support quality improvement. This is the model we've used since about 2002, acquiring data currently from about 40 different electronic health record systems. That data is brought in. We have an organization or operation-specific normalization routine we run. Even with the same electronic record systems, there are often multiple versions that have come in over time. Some practices update, some don't, and that has implications as well. We then have a general normalization routine. We run that through, so we try to standardize the data across all systems. Each group that we get data from has their own instantiation in our database, so we don't commingle data from different practice settings. We then run queries that run across those settings, which we use both for quality improvement, where we use identified data, and then for research, where that data across those systems is de-identified. But again, when we query that data, it's not commingled, it's actually querying those different databases. So that's the method we've been using now for many years, and allows us basically to work with any electronic record system to run this model. And again, working across a geographic area, and I'm sure COSEC is used as probably a very similar model to create these data warehouses for quality improvement and research purposes. I'd like to just talk a few minutes about Target BP, because this is one where we use the electronic health record extensively to be able to drive improvements in blood pressure control. It basically has three components: measure accurately, act rapidly, and partner with patients. So I'll just take a moment to describe each of these three phases, again, driven very much by electronic health record system data. So there are basically two methods. You can either embed the quality improvement into the electronic record as part of your workflow, or you can work outside the electronic record, creating these data warehouses that allow reporting back. So measuring blood pressure accurately. And I will say this is a program that was developed with Johns Hopkins and AMA. We were involved in that development process. It was then field tested in Baltimore and Chicago. It worked not as well as they had hoped. They had about 500 pages of material, 2 large binders of materials. They then came back to us and said, can you help us with this program? And so we took the 500 pages, distilled it down to about a 10-page book, and then developed a way to really monitor each of these 3 processes and give that feedback on a regular basis with patient-specific actionable lists. You've already heard from Dr. Vieira some of the challenges with measuring blood pressure, and most of our challenges lead to a blood pressure that's higher than the true blood pressure in the artery. So the challenge in the clinic, as he mentioned, is twofold. One, getting a pressure that accurately reflects what's in the artery, and then getting a pressure which accurately reflects the average daytime blood pressure. So both of those are challenges in the clinical setting. We'd like to find ways to help overcome that, and we believe the measure accurately component of this does get to both an accurate and a representative blood pressure. But these are just some of the errors that occur. Fortunately, not in every patient do all of these, but often multiple challenges. So what we encourage, obviously, is that the initial intake blood pressure is done according to the standards, and I think you know what those are. And if that initial blood pressure is elevated, then we recommend the patients taken to their exam room properly positioned, and then use an accurate automated device that obtains 3 readings at 1-minute interval and averages those. What's been shown is that average blood pressure when the patient was alone much better reflects average daytime ambulatory blood pressure than does our usual office blood pressure. Now, is it perfect? By no means. It's just that the variability is significantly less versus the ambulatory than if you use your usual office blood pressure, but it is a better reflection of average daytime. So in this case, we recommend no initial rest. The patient's put in the room, the automated monitor is placed, the device is activated, the staff leave the room, they're gone for about 5 minutes. It requires workflow redesign because they can't lose those 5 minutes. They have to be productive, so it does require some practice redesign. If the practices do not figure out how to change their workflow, they will not continue to do the automated office blood pressure. We found that an external person coming into the clinic, a facilitator, is often required to get that technique to be a durable change in the practice, but can be done. Now, what I'm showing at the bottom there is that about 30% of the patients had a non-hypertensive automated office after they had an elevated initial blood pressure. The average reduction for that group was 17 systolic and 7 diastolic. We believe that that's capturing a lot of the white coater office effect by doing the automated office blood pressure. For those who maintain hypertension, the systolic is only falling about 5 millimeters. So it looks like there are a couple of groups of patients that come out of this. I've been talking with some colleagues at the University of Pittsburgh, and their findings are almost exactly what we see with the use of the automated office blood pressure in this program. So act rapidly. If you confirm the blood pressure is elevated, let's make sure that the pharmacotherapy is adequate and the patient has been trained in the lifestyle changes that they should be implementing. We give the clinic's boxes of Dash for Good Health Southern style, an eating plan that we've developed that's based on a lot of Southern foods, but prepared in a way that makes them consistent with a DASH eating plan. It tastes good and it doesn't cost more because there's no patient that's going to pay more money for food they don't like, and so we've intentionally designed it to taste good, not cost more, but be consistent with a DASH eating plan. So we give those away to the patients. We do recommend a standard pharmacologic therapy in the absence of compelling indications. If people have compelling indications for medications, certainly give them the medications for which they have compelling indications. We sort of like the British National Institute for Clinical Effectiveness, where in the younger and Caucasian patients, you begin with a RAS blocker. In the older patients, African American patients, beginning with a calcium channel blocker. Then you simply add the complement of that, so at step 2, they're on both a RAS blocker and a calcium channel blocker, adding the diuretic as a third step. And we also encourage very much the use of single pill combinations. Amlodipine benazepril is generic, and many of the pharmacies in our area have that on the $4 formulary, so they can get all doses of benazepril amlodipine for $4 a month. If they're going to use a diuretic, we prefer indapamide, which is on the $4 formularies. But when they go to 4 medications, and our patients are very good at counting pills, and they don't like to take a lot of pills, we often encourage them to keep the benazepril amlodipine and then go to hydrochlorothiazide spironolactone. And I think of patients that are adherent, that will at least follow a reasonable lifestyle pattern. You will control a good 80 to 85% of your patients with those 2 single pill combinations, which are inexpensive and they're generically available. And our patients really do count pills. These are just some 3 to 4 BP med combinations, again simplified, but as I say, you know, once you get to the more complicated patients, who require 4 meds, we like 2 single pill combinations, but otherwise use, and most patients require at least 2, so a single pill combination goes well. The other thing I will say in the context of multiple chronic conditions, so the average Medicare patient, we have about 58,000 in our Medicare Shared Savings Program. The average Medicare beneficiary has 6 chronic conditions. The most common is hypertension. The heart failure patients on average have over 10 chronic conditions. In our database, MSSP, about 94% of them are hypertensives and about 88 to 90% are hyperlipidemic. 50 to 60% have COPD, 50% are diabetic, and 40% plus have a major mental health diagnosis, serious depression, alcohol, drug abuse. We find in our Medicare beneficiaries that's only the complex patients typically that have these behavioral health. The patients that have 1 or 2 diagnoses, it's almost never a behavioral health diagnosis. The reason I'm saying this is these are complex patients, and while I'm showing you an algorithm for managing one disease, particularly, and many of these are elderly, they are going to come in as complex patients. So I want to recognize that in how challenging this problem can be. And finally, the best blood pressure measurement, whether it be repeated 24 ambulatory, and the best treatment regimen and the best lifestyle instruction goes nowhere if the patient is not engaged. And we've seen perhaps some of the largest benefits in this particular area of the program. We use a proxy for that. So for the measure accurately, we look at, of the initial elevated blood pressures, what percentage of those patients get an automated office? And so the clinicians and the clinic staff get that feedback every month, and they get a patient-specific list of who got it and who didn't. Act rapidly, which patients had intensification of their antihypertensive regimen if we verified that that pressure was elevated. And then as a proxy for engaging the patient, we look at how much the blood pressure falls when the medication is intensified. Patients that are engaged, well, their blood pressure will fall more when you prescribe more meds than patients that aren't engaged. So they get those 3 process metrics on a regular basis. We talk a little bit about the dimensions of adherence. There are 5 dimensions, and that's why no single intervention will drive the kinds of adherence that we like to see. So there are socioeconomic factors, patient factors, treatment factors, comorbid condition factors, and then healthcare system-related issues. And I think if you can, it's a little complex, but remember that these are the different categories and identify what the issue or issues are for your patient, you have a better chance of addressing the adherence issue. So this is the logic model we developed. This is also part of the MAP program. If you go online with the American Heart, you will see this logic model. We developed this. So again, the first step, measure accurately under evidence-based strategies. I'm going to just 2 columns, the evidence-based strategy and the monthly metrics. So measure accurately, initial pressure is high, do an automated office. We look at percentage of those patients that we call confirmatory automated office. Confirm the blood pressure's elevated, how often do we intensify the regimen? That's our therapeutic intensity, or inertia. We've actually changed it to intensity, because there's one thing I neglected to mention. When we looked at our database a couple of years ago, about 600,000 hypertensive patients, of the individuals who were not controlled, 80% of them were not on 3 meds at half maximal doses. So 80% of the uncontrolled hypertensives in our database were not on 3 meds at half maximal doses. You get about 80% of the benefit in terms of blood pressure reduction with any medication at the half maximal dose. So in general, we're much better off if the patient's uncontrolled of adding another med at half maximal than doubling the dose of a current med. In general, you get about 4 times the blood pressure effect with that. And so again, that's something that we encourage. And then, did the patient adhere to our intensification and our lifestyle? How much does the blood pressure fall? All clinicians, the staff, clinics get a monthly feedback report that shows them their blood pressure control, how often they're doing the confirmatory automated, how often they're intensifying the regimen, and how much the blood pressure is falling when they intensify the regimen. To date, most of the improvement has been driven by the measure accurately in the partner with patients. We really haven't yet significantly changed. It's reasonable, but I think we've still got a long way to go in the therapeutic intensity and getting patients to at least 3 meds at half maximal doses if they're uncontrolled. In the initial clinic we did was a predominantly low-income minority clinic, Medicaid predominantly insured. The clinic went from 60 to 90% in 6 months with this program. The department chief got so excited, he said all of our clinics are going to do this, so this was the next 16 clinics. We initially, working with American Heart on this and American Medical, said we were only going to do it in the clinics that were ready. And about 5 clinics were ready. We were implementing Epic, and about 6 clinics were on Epic conversion when we implemented the program, which made it challenging. Other clinics had turnover of physicians and clinic staff. But nevertheless, the average in these 16 clinics with over 16,000 hypertensive patients was about a 10% improvement in 6 months. We then no longer do any practice facilitation after the first 6 months. We simply give them their monthly reports and their actionable list, and they maintained about 90% of the improvement with no further input. Where many QI programs, you lose the efficacy by 1 year. So with MAP, Target BP, it looks like you sustain efficacy. But again, the issue is, are your changes in measure accurately, act rapidly, and partner with patients durable? We think this actually could be a progressive improvement program if you pay attention to those 3 process metrics. So let me just summarize. Epic and quality improvement. Epic is an excellent system, but it requires a lot of care and feeding. And really to customize it to fit your practice requires expertise in programming, and these Epic programmers come at a price. There's a lot of competition for them. And so it's a fairly pricey endeavor to get these folks that can really tailor that system to meet your practice requirement. But if you're part of a large system that provides that, it's excellent. We use basically a clinical data warehouse model, whether it be Epic or others, to get information in and data back. I haven't talked about it, but a lot of clinics we work with get a daily huddle report. So we get their daily scheduling in the afternoon, and before they come in the next morning, they get a gap report on chronic conditions for patients coming in that day that gives them very specific, actionable information. That's we found to be very useful in being able to sustain these quality improvement practices. Target BP, it's an effective program. I think it'll be even better when we get it embedded in Epic, which we're in the process of doing, but you can certainly run it as you would with any other system with a data warehouse. So again, QI customization is effective with Epic. It's costly. You can either run the quality improvement embedded in your EHR, or you can have data coming to you externally back to you to use in quality improvement. We think embedded is better. And then key components of a quality improvement program, I haven't made this clear, you need the process metrics that drive your outcome, because if you don't get your outcome, you need to know why. And with MAP, it's very clear. If the program is not working, either we're not implementing the 3 process metrics. I mean, it comes right down to that. If you implement those 3 process metrics, you will get hypertension control. And if you want to do better, you find out which does that. So again, the plea I would make is if you're driving a quality improvement program, monitor the process. Does it drive the quality on a regular basis so you know why your program's working, why it's not working, and how you can make it better. And multiple chronic conditions in our older patients, average in Medicare is 6. The heart failure patients have an average of 10. The CKD patients have an average of about 8.5 chronic conditions. These are patients that have 90% plus hypertension. They're challenging, and so while I'm showing you one condition, we know that you're managing patients with multiple chronic conditions. Let me just mention one thing that happens. Our EHRs are pretty good at drug-drug interactions. They're pretty lousy at drug-disease interactions. Our heart failure patients are depressed. Many of them are prescribed citalopram, Celexa. It is the SSRI that has the greatest impact on prolonging the QT interval and increasing risk for sudden death. Ross was here talking about sudden death. Our EHRs are very lousy at picking up these drug-disease interactions that put patients at high risk for serious problems. So in one of the heart failure programs we're doing, we give the clinic a list of contraindicated medications. You've got a patient with 10 chronic diseases getting 1A indication drugs that have a level 3 contraindication for another chronic condition. And our EHRs are absolutely lousy at picking that up. So I just mentioned that as perhaps another unintentional contributor to sudden death is giving patients that are at risk for arrhythmias drugs that significantly prolong the QT interval. It's one of the worst things we can do. It's unintentional, but it happens. So I'm going to stop here, and we've got more presentations. I'm going to get out of the way, and we'll move on with the program.